have treatment regimens been altered or modified to spare patients a trip to the clinic? I know that in talking to other physicians, they were saying that chemotherapy and immunotherapy, because they can lead to myelosuppression and immunosuppression, they've tried to hold back a little bit on that. So have you seen any treatment modifications being made?
Yes and no, because for example, we send home all the survivors. In cancer, we have in America, we have 1 million, more than 1 million, no, many millions of survivors. And, this is the people that comes every 3 months, 4 months, 6 months. If they postpone one CAT scan or PET scan, it's not a big deal because they are already cancer free and they are not in any treatment. So that's why the first thing for us was to send home all the survivors. And we still have a large number of cancer patients, and it's very hard to stop treatments. Especially I do lung cancer, most of the patients are stage 4. So everybody is on immunotherapy, chemotherapy, or target therapy and oral medication. These are hard to stop because the patients, it will progress sooner than later. That's why we have continued to treat them. With the patients on target therapy, on the pills, sometimes it's easier to do follow-up by telehealth. We have done in our healthcare system more than 12,000 telehealth visits in the last month. And the cancer patients on target therapy can be included there. We still like to check their blood, maybe not every month. Now, to the COVID, maybe we can postpone some weeks the blood checkups. But these are the easy ones. But for sure, all the patients on immunotherapy, all the patients on chemotherapy, they need to be seen and they need to come. So these are the ones that we are really prioritized for our follow-ups. No?
Great. And so what about for new patients who are presenting to the clinic with lung cancer and they require immediate intervention? How has the pandemic impacted those patients and kind of your treatment for them, I guess?
Yeah, for new patients, if they are stage 4, the disease progresses fast. Like any other cancer, probably stage 4 breast cancer, colon cancer, we need to put them on treatments sooner than later. So that's why we had to treat them. Maybe we have postponed a little bit early stage patients. For example, you need a surgery for in 2 weeks from now. A big deal. Every day comes in during the COVID pandemic because we don't know if we're going up, we're going down. That the search is over and nobody notices, and that is why that patient can be maybe accommodated. Already had surgery. You already had surgery for lung cancer, for colon cancer, for breast cancer, and now we need to give them chemo, and there is a lot of flexibility for the chemo in our standard of care. If you have surgery, the chemo can start 6 weeks later, can start probably 8 weeks later. So these are the patients that probably also we can move and tell them, listen, don't come in this month, come next month. You're still inside the window of opportunity to benefit from the adjuvant chemo, and don't have to come now that we are in the middle of the crisis, no? So there is more opportunity with that type of new patients. Also, a lot of times, some of the new patients need workups. A lot of times we are consulted for a big, long mass, then there is no biopsy. So the patient needs a brain scan. So all of these procedures are being done, and so we have time to decide when to start the treatment.
That's absolutely good points. And then you did touch on this, but if there's anything else that you'd like to add, I know that the surgical approach has been, pretty widely impacted by this. So in terms of, I guess, kind of handling that, I know that, in terms of ventilators and the materials, I guess, that they're using in the operating room, they're for the patients who are dealing with the COVID.
We do a lot, thousands of PPE We were very worried about the surge, so we even took all the ventilators that we had for our patients. We had patient surgical clinics in our healthcare system. We start to count one by one all the ventilators, thinking that it's going to be a big surge. So that's why all the ventilators were available for the just in case we need for COVID. So that's how elective surgery. Um, you know, most of them are non-cancer. A lady with a gallbladder, some stone. It's more relative, you know, if the surgery is elective or not. Why we more complicated than lung cancer, because in lung cancer, yeah, you have the mass and you have sometimes cough and some symptoms. But sometimes colon cancer patients come obstructed. So there's like some sort of urgency, emergency, because patient may find no problems, he gets better in the hospital with some care, and then he goes home. But what you mentioned is very important. We need this 895 mass probably if we want to go back to business as usual, because now we're taking care of the COVID patients, so we're not fully operational. Our hospitals are not fully operational. So when everybody is back working 24/7, we're going to need a much larger supply of this protective equipment. So that's really a challenge, you know. So we need to be sure that we have enough for everybody.
Absolutely, good point. So let's see. So are you finding it difficult to differentiate between the symptoms associated with treatment in this space, or how patients are presenting with lung cancer, versus those associated with the COVID-19 virus?
Yes, that's correct, because especially in lung cancer, it's very complicated. Our patients, normally, a lot of them, the smoker ones especially, they already have COPD. So they are coughing all year long, and they're using inhalers, prednisone, a lot of stuff. And now they are coughing because they have lung cancer. And not everybody gets symptoms of coughing with lung cancer, but a large number gets because fluid or obstruction. And now, for example, we do radiation therapy sometimes in lung cancer, and we do immunotherapy for lung cancer. And you know, pneumonitis, inflammation of the lung, is a complication, a potential complication of the radiation therapy or the immunotherapy. And that's our baseline. We haven't even started about COVID, and I already mentioned to you tons of reasons why our lung cancer patients can be coughing. So that's why now, on top of that, that patients are coughing is a real challenge, you know. So we screen our patients every time that they have for a visit. But we screen our patients every time that come for chemo. We take the temperature. And I think, for example, one way to go back to business as usual is maybe once that we have the antibody available, that we can test the blood and be sure that they are already, they have been already survived infection and they have immunity. Maybe that would be better. The other way is to test them for the virus, but that guarantee is only that moment. No, that you do it in immediate test. Okay, the patient doesn't have the virus, but maybe this patient needs to come for weekly chemo. That means you need a lot to spend a lot of resources testing them over and over. But that's also another option for to the hospital. We test the patient. So we have COVID units. We have ICU. All of us feel more comfortable moving around the non-COVID units where our cancer patients are, because we already have tested them. So that gives us some security that the patient will be safe and will be safe.
Absolutely. And that kind of goes into my next question. You know, you mentioned of the patients with COVID and those who do not have it. What other safety measures have been put in place at your institution?
To separate the patients, first of all, the patient. have not afford to have any. We respect, especially we have a lot of patients that are with this chemo. So for the hospital, so fortunately that we have not been overrun by this disease. If you see what happened in Italy, maybe sometimes in Spain, it's very sad because that they therapy. We still, as I said, we to go to the ER or to help in any COVID unit. So in the hospital, the floors are separated. We have COVID floors. So in each of our hospitals, the floors are separated. The elevators are also it has a. The stairs are sign that this is a stair maybe that goes to a COVID unit to try to be extremely cautious. Yeah, in a non-COVID elevator, maybe you can have some relative coming and but there is no guarantee. But at least we try to be organized and the same with the personnel. No, our nurses that work for COVID is a team, and the ones that don't work for COVID. I think that help us in that way. Be exposed.
Points. I've not heard about the elevators yet. So let's see. So you talked a little bit about, kind of the shift toward telemedicine and telehealth. How are patients responding toward moving to that virtual platform? And are there perhaps if it's implemented, after the COVID-19 pandemic is gone?
Telemedicine is very interesting because, for example, we have this Epic software that is very, so everybody knows what I'm talking about. And Epic had the telemedicine capability for several years. I remember that three or 4 years ago, all the patients communicate with us through email. They can make their appointments online. They can check the results. Now we never used was the telemedicine. And finally, like 2 years ago, 1.5 years ago, we start to invite patients to start to do telemedicine. And you can imagine the patients were not excited. The doctors were not excited. Nobody was excited. So that's why it was totally underused, despite the fact that we had the capability. And as I said, probably in America, everybody has the capability. They have this software. And now we had to ramp up in a very short time. A lot of patients are scared, so they are happy that you can see them by telemedicine and treat them. The challenges, in Florida, we have a lot of senior population. I have 97-year-olds, 95s, 94s in very good shape, but they are not as friendly with the technology. The technology is not friendly with them, and we have challenges. So I'm very happy that the government lifted the restrictions for privacy. We were only allowed to use a specific software before, like Epic, Cerner, all of these encrypted softwares for medicine. For example, we were not allowed to use WhatsApp, that is very popular in the street, Skype, Doximity, all of these commercial platforms. Now to facilitate the communication, if one of my patients don't have Epic, we call with WhatsApp, we call with Skype, because the government has allowed us to use that. I guess it's only for the time of the pandemic. The problem with these softwares is the security of the privacy information of the patient that can be hacked. Some of these softwares like WhatsApp, they said that they are encrypted too. Doximity, they said they are encrypted too. But anyway, it's not our fault to argue. But now we're using any platform to communicate with the patients to overcome all of these challenges. Payers are reimbursing the doctors and the other providers like nurse practitioners for these services. When we start to use telemedicine, there was a challenge in the payments. You know, the providers may not going to get paid because all of these insurances don't feel familiar with telemedicine. So, but it has helped for telemedicine, and so the doctors and the patients at home. You know.
Absolutely. And let's see. So I think we touched on that. So kind of looking to the future, you know, we're hoping that this goes away sooner rather than later, but how do you see it impacting the medical field going forward? You know, is there going to be a lasting effect? Do you think that people are going to be a little bit more apprehensive to start coming back into the clinic, you know, in a regular way?
I think this is going to change us forever. I think when the SARS virus came and the MENA SARS, the second SARS came, I don't know, you know, in America, we heard about that. It was very scary. I saw this movie, Pandemic, but it was not something, there was not something that affect us. No, I even remember, I love to go to Asia for vacations, and you see all of these people using masks, and I never think that I want to use a mask because it was not our problem. It was not a problem, American problem. And now I think it's going to really change the way that we practice. For example, telemedicine is not going to disappear. I think after we have tested and used it, some patients are going to prefer to continue using telemedicine if possible. I think also helps, you know, because for us it was a challenge when the patients come for second opinion from far away. They had to drive 3 hours, 4 hours, and most of us, we never wanted to give a second opinion over the phone. We prefer to see the patient, examine the patient, and a lot of us don't like to give a second opinion over the phone, so I never did it. But now I have my first second opinion. I give a second opinion to a patient at least 6 hours away. And I think that was great because I didn't obligate the patient to fly to see me. And I think that was good. I think we did a great service. So that's why maybe we're going to expand the telehealth will help us expand. I cannot even imagine if you're in a rural area. I'm the co-chair of the Centers of Excellence for the GoTo Foundation. We have 40 cancer centers, and a lot of them are in Western Tennessee, all of the rural areas, and so maybe the patient is necessary. Even for blood draws, you know, we have commercial enterprises like everywhere. So maybe the patient can get a blood draw in the labs, so the patient don't need to go to see you to get a blood draw. They don't need to see you to discuss the issue, only for treatment, you know, and that helps a lot the care of the patient. So I think we'll have business as usual. And as you know, also, we don't know if we are going to get immune from this virus. We don't know if it's coming next year. So I fly a lot all over the world giving lectures. I don't know how it's going to be anymore. Maybe the meetings are now going to be more virtual. So this is going to change the way that we practice oncology, the way that we teach oncology a lot. I think it's not going to be the same. I hope we're getting something good from this.
Absolutely. Yeah, we've been dealing with the virtual meetings and figuring out all of that. So it'll be interesting to see how it goes going forward. So my final question is, what advice do you have to colleagues in this space who are treating patients with COVID-19 and who, may be seeing an influx of patients coming in who, they haven't needed to necessarily address that patient population to begin with. So what's your advice to colleagues, right now?
Well, the most important thing I think is to always be focused. Don't panic. As I said, we got very scared when we saw what's happening in Italy and Spain, and we thought that maybe it was happening the same here, and even in New York. Remember, we were preparing for. It's horrible what's happening in New York, but actually we were psychologically preparing ourselves for worse. I think to be prepared is important. I think we're going to be much more prepared for any pandemic after this. I think healthcare needs to get more resources, and they will do. And for the doctors, I think is to be focused. We are fortunate in America that we have more resources, and that helps. I'm talking about especially because in Europe there were a lot of ethical debates about if we should continue doing cancer care or no. And some of them were very sad debates, if you are cancer, you don't get a ventilator. If you are a senior person, you don't get a ventilator. The ventilators is for non-cancer people or for younger people. I remember that in Latin America, I participated in a debate, the same thing, because the patient had lung cancer and they got COVID, they don't have a right to be ventilated anymore because they have to keep the ventilator for somebody else. We have been very lucky and blessed in America that we have not faced this. Of course, we need to be prepared, but I think we can still focus in providing the best cancer care of the world, with the best standards, and helping others teach them about that. And that's why I think this is important, that we don't lose focus and we don't panic, and we keep ourselves organized. And I am really sure that even if we get the same pandemic next year, it's going to be much better. The way that we fight, the way that our success, and hopefully we will have less losses than now.
Absolutely, good points. Is there anything else regarding the COVID-19 pandemic and lung cancer, or just your experience in the healthcare profession right now that you'd like to add that I didn't ask you?
Well, there is a lot of things to talk about lung cancer, no? And but for us, this bothers me, the pneumonitis. No, we need to learn how to differentiate. We are still in the process to learn how to differentiate the pneumonitis, the lung inflammation, from immunotherapy and target therapy from other conditions like pneumonia. And now I guess we need to rush and learn how we can find tests and other biomarkers maybe to differentiate when the patient has COVID, when the patient, I guess if we get a good test for COVID and the patient presents with a pneumonia, if the test said it's COVID positive, we know it's COVID, so I don't have to worry about blaming the drugs for this. No? That's why if we get a good test, maybe that will help us to differentiate, and we will allow to practice the care of lung cancer better. Because as I said, the pneumonitis and the lung inflammation, it was complicated before the COVID, and it's getting a little more challenging now.
Absolutely. Well, thank you so much for meeting with me. Is there anything else that you'd like to add?
No, I really appreciate what you guys do on Life. I love to be in your programs because I think education is and also now that we are learning a daily basis, it's not only education, it's like you have to disseminate all of this new knowledge, experience, and content away. And as I love your programs, and I think I hope you guys keep doing this because it benefits providers, benefit patients, benefit general population. So thanks for doing this too.
Thank you very much.